Welcome to the Deep Dive, where we take a complex challenge, digest a mountain of sources, and give you the essential distilled truth.
Today, we're embarking on a crucial investigation into a global public health crisis that often hides in the most mundane, everyday setting, the doctor's office.
We're deep diving into the hidden costs and the really complex drivers behind antibiotic overprescribing.
And the scale of this problem is, well, it's genuinely stunning. We reviewed the research, and the findings paint a stark, consistent picture.
What are we talking about numbers-wise?
We're looking at roughly 30% of antibiotic prescriptions written in the U.S. outpatient setting being deemed completely unnecessary.
30%, that isn't just a statistical error.
No, it's a foundational flaw in how we deliver healthcare.
And if we expand that definition, right, if we move beyond just unnecessary to include what you might call inappropriate use.
Right, like the incorrect agent selection, the wrong dosing, or durations that are just way too long.
Then that inappropriate use could soar as high as 50% of all prescriptions.
Think about that. Up to half of all antibiotics dispensed may be fueling antimicrobial resistance without delivering any patient benefit whatsoever.
Let that number really sink in for you, the
Yeah.
listener. That core 30% unnecessary rate, that translates to a staggering 47 million excess prescriptions
Every single year.
every single year, and that's just in the United States.
Exactly.
So our mission today is to unpack our source material, to understand the behavioral roots of this pervasive overuse, track its alarming consequences for individual patients and global health, and explore how new technologies like telemedicine are inadvertently giving us the data we need to fix the problem.
And we'll see very clearly that the main source of this inappropriate prescribing, at least in outpatient settings, it revolves almost entirely around acute respiratory infections, ARIs.
So your common cold, your sinus infection.
Exactly. Whether it's sinusitis, bronchitis, or a sore throat, this is where the daily battle against antimicrobial resistance is truly being fought. And it's where a misplaced sense of caution has led to really dangerous cumulative global consequences.
Okay, so let's unpack that historical context, because without the miracle of antibiotics, there is no paradox to discuss.
That's right. Before their widespread development in the 1940s, an infection, even a common scrape, a mild pneumonia, or a sore throat caused by a bacteria.
Could be a death sentence.
It could, and it often did lead to critical illness, the loss of a limb, or certain death.
The development of penicillin, it's heralded as one of the greatest medical advances in human history for a reason. It fundamentally changed the trajectory of the human race.
For the first time, we had a reliable weapon against once lethal microbes. Its impact was so profound and widespread that it directly shifted the leading causes of death in developed nations.
So we stopped dying from infections.
We moved from predominantly dying from communicable diseases infections to non-communicable chronic diseases like cardiovascular disease, cancer, and stroke. A huge shift.
And we can absolutely quantify that impact. I think we often forget just how severe life was before this medical revolution.
Well, some studies estimate that the average life expectancy prior to the widespread availability of antibiotics was around 47 years old.
47.
The massive increase in survival and quality of life that followed really cemented penicillin's initial reputation as a true miracle drug.
Its success then obviously prioritized its commercial production and mass distribution.
Oh, absolutely. We saw massive scaling efforts, famously reaching a production rate of 4 million sterile packages per month during World War II, just to treat Allied soldiers.
But as the use of penicillin intensified and rose to meet that global demand, an almost predictable and, entirely paradoxical phenomenon began to occur.
Which is what we now know as antimicrobial resistance, or AMR.
And it's important to say this isn't a flaw in the medicine itself. It's just
Basic, brutal evolution playing out in a petri dish. A bacteria's primary goal is survival, and its ability to survive depends on outmaneuvering its newly introduced arch nemesis, the antibiotic.
So it's a naturally occurring biological mechanism, an evolutionary process that empowers bacteria to adapt and then survive exposure to the drug.
That's the key mechanism. Natural selection dictates that the bacteria sensitive to the antibiotic are killed off. But any bacteria that happen to possess a trait, a mutation, a gene that allows it to resist the drug,
It survives.
it survives, and then it multiplies exponentially. And this results in the proliferation of more dangerous, untreatable bacteria. This resistance is often achieved through the development of specific antibiotic resistance genes.
And here is the truly terrifying part of that process. These microbes aren't just evolving individually.
No, they can critically share their newly learned defense mechanisms with other bacteria, even those of different species.
Spreading resistance rapidly and dangerously through what's called horizontal gene transfer.
Exactly. And we refer to these highly resistant microbes that defy even our most powerful last resort antibiotics as superbugs.
What's so fascinating here and deeply sobering is that the creator of the miracle drug, Alexander Fleming, he recognized this potential disaster immediately.
He did. He was so farsighted that he made an ironic and profoundly prophetic prediction back in 1945, years before the full weight of the problem was even felt.
He famously warned the world, I think it was in his Nobel Prize acceptance speech and in interviews around that time, that the misuse of penicillin could be the very thing that leads to this crisis.
Yes, his quote is infamous, and it still rings so true today. The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with a penicillin-resistant organism.
Morally responsible. That's an incredibly strong statement.
It is. It places the responsibility for a global health catastrophe squarely on the shoulders of thoughtless, casual overuse. And now, 80 years later, his warning has intensified into an unprecedented global public health crisis.
So let's talk scale, because the statistics today are terrifying. They move this beyond a theoretical problem and into a very active global threat.
The Centers for Disease Control and Prevention, the CDC, they meticulously track this data. Their estimate is that 2.8 million antibiotic-resistant infections occur in the U.S. each year.
2.8 million.
And that rate, while it's massive, is also considered conservative. It results in more than 35,000 people dying annually as a direct result of these resistant infections.
And crucially, that number doesn't even count the additional morbidity and mortality from the side effects of antibiotic overuse, right?
That's a great point. Things like the deadly diarrhea caused by Clostridioides difficile, or C. diff.
C. diff, yeah.
That accounts for an additional 3 million infections and 48,000 deaths in the U.S. annually.
So it's a vicious cycle. We treat an infection unnecessarily, which then causes a different, often more severe infection that is even harder to treat.
Exactly. And if we connect this to the bigger picture, the economic toll is truly staggering.
What are we talking about in terms of cost?
The CDC estimates the cost of antimicrobial resistance in the U.S. alone is $55 billion every single year.
$55 billion. How does that break down?
It breaks down into about $20 billion in direct healthcare costs, so the cost of treating sicker, more resistant patients, and then about $35 billion for loss of productivity due to illness and death.
Just to put that into perspective for you, the learner, $55 billion is roughly enough money to fund NASA's entire operating budget for 2 years.
And that immense sum is just disappearing into the consequences of resistance annually. It's an unsustainable drain on our economy.
And globally, the threat is even more dramatic.
Oh, absolutely. Both the World Health Organization, the WHO, and the United Nations have declared AMR a global public health concern, recognizing its geopolitical implications.
And the UN has warned that if no definitive action is taken, drug-resistant disease could lead to, what was the number?
10 million deaths annually by 2050.
10 million.
That would surpass cancer as a leading cause of death. And they also warned it could force up to 24 million people into extreme poverty by 2030. This moves the conversation beyond just medical practice and deep into humanitarian and economic disaster territory.
Okay, so let's unpack this core mystery. If the stakes are this high, 35,000 deaths a year, $55 billion in costs, Fleming's warning hanging over us, why? Why, despite overwhelming evidence, history lessons, and rigorous medical training, do highly trained healthcare providers continue to overprescribe? We know that 1 in 3 antibiotics shouldn't have been prescribed in the first place.
We have to move beyond assuming this is just a simple knowledge deficit. Most clinicians, they know the risks of AMR. The problem is, it's complex and profoundly multifactorial.
So it's not about doctors not knowing the science?
Not primarily, no. We certainly see internal professional drivers for poor prescribing habits. Things like a lack of continuous specialized infectious disease education after their initial training, and perhaps most importantly, just the perpetuation of the tradition of prescribing, rather than strict adherence to evidence-based practice.
But the external factors are often the most compelling drivers of this cognitive dissonance.
Absolutely. And the most cited external factor is the pressure to practice what's called defensive medicine.
Defensive medicine.
Clinicians often feel compelled to practice defensively, prioritizing the minimization of malpractice liability and avoiding negative outcomes that might lead to a lawsuit. The fear is visceral.
The fear being that if a patient comes back sicker, or if a rare bacterial infection was missed,
The provider fears they might be held responsible for withholding a drug.
and that fear of liability is powerfully compounded by the commercial realities of modern healthcare, especially the focus on patient satisfaction scores.
That's a huge one. Many studies have been published that conclude that patient expectation to receive an antibiotic, often regardless of medical necessity, significantly influences the prescriber.
And critically, research has established a direct correlation.
It has. Patient satisfaction, particularly when it's measured through patient surveys and ratings, is directly correlated with the likelihood of medical malpractice suits being brought against the clinician.
So it's a vicious cycle of incentivizing poor decisions.
Completely. Doctors may feel compelled to prescribe just to satisfy the patient, to avoid a complaint, a bad review, or the fear of litigation, rather than playing it safe by strictly following the evidence.
The result is irrational antibiotic prescribing driven by external pressure and just system design flaws.
Now, this is where the behavioral science delivers the receipts, because new data that was generated during the pandemic from the acceleration of telemedicine has given us the first truly measurable evidence of these specific behavioral drivers.
So we can actually see it in the data now.
Yes. Researchers from the Cleveland Clinic, using data from Amwell, a large telemedicine company, they set out to assess the two major concerns doctors consistently raise about reducing antibiotic prescriptions: patient satisfaction and time constraints.
And the patient satisfaction data provided a remarkably clear measure of this pressure.
It did. Telemedicine companies, much like rideshare apps or retail services, often have patients rate each visit on a 5-star scale immediately after the encounter.
And what did they find?
They found a massive difference based on whether a prescription was issued. Patients who received antibiotics were significantly more likely to give their doctor a 5-star rating,
How much more likely?
hitting a huge 91% compared to only 71% of patients who did not receive an antibiotic.
Wow, that is to 20 percentage point gap.
It's an enormous difference in perceived care quality based on a non-medical outcome. This finding highlights how the prescription, in the modern consumer-driven healthcare environment, acts as a satisfaction surrogate.
So the doctor who gives the patient what they expect, even if that drug is medically useless, is rewarded with a superior rating.
Which in turn reduces their personal liability risk. This essentially turns an unnecessary antibiotic into a low-cost insurance policy against a negative rating.
And the other piece of pressure they measured was time, which is perhaps even more telling about the logistics of clinical burnout.
Right. Explaining why an antibiotic isn't needed, talking about viral natural history, side effects, and AMR, it takes time away from an already overwhelming workload.
And with telemedicine, you can measure that precisely.
The length of every telemedicine visit is automatically recorded, providing precise, objective data. The researchers discovered that visits that ended without an antibiotic prescription lasted about a minute longer on average than those with a prescription.
Just a single minute, that seems negligible, but
But that 1 minute is a critical barrier in a high-volume clinical practice. Telehealth interactions can be incredibly brief. Some studies cite a median time of just 5.5 minutes for the entire interaction.
so when a clinician is facing a high workload, time constraints, and the pressure of a waiting queue of patients,
Taking that extra minute to educate the patient on the natural history of their viral illness and the dangers of antibiotics becomes the path of higher resistance. It requires mental energy, emotional labor, and the risk of a confrontation or a bad review.
so it is demonstrably easier and faster to just write the script, fulfill the patient's expectation, and move on.
The system encourages speed and compliance over evidence-based communication.
Okay, moving on, we need to zero in on the main battleground where these systemic pressures play out.
Acute respiratory infections, or ARIs.
These are consistently the main source of inappropriate prescribing in outpatient settings.
And the stark biological reality, according to organizations like the CDC, is that 98% of infections such as rhinitis, acute bronchitis, and most cases of sinusitis are viral in origin.
Meaning antibiotics are entirely futile, yet these are the conditions most frequently treated.
Let's start with sinusitis inflammation of the sinus cavities. This condition accounts for more antibiotic prescribing in the United States than any other single diagnosis.
And while bacterial sinusitis does exist?
The overwhelming majority are viral, which just increases costs, adverse reactions, and resistance with little to no benefit.
And we have hard numbers that show the disconnect between clinical practice and the
We
guidelines.
do. A large chart review study looked at adult primary care patients visiting for acute sinusitis and measured how many met the rigorous Infectious Diseases Society of America, or IDSA, criteria for an antibiotic.
And what did they find?
They found that only about 50% of the randomly selected sinusitis visits actually met those IDSA criteria.
And those criteria are strictly defined, right, by persistent, severe, or worsening symptoms that signal the viral infection may have given way to a bacterial one.
Exactly. Yet the national prescribing rate for sinusitis remains high, around 72%.
So to be crystal clear for the listener, more doctors are prescribing an antibiotic for sinusitis than the evidence suggests should ever receive one.
That 22-point gap represents millions of unnecessary prescriptions annually. It's an act of clinical caution that has become globally reckless.
And the problem isn't just if they are prescribed, but for how long they are prescribed.
Right. Even in the cases where an antibiotic is warranted, the IDSA guidelines recommend a short course, usually 5 to 7 days of therapy for uncomplicated cases that respond favorably. The goal is to minimize drug exposure.
But the practice doesn't align with the guidelines.
Not at all. A study looking specifically at acute sinusitis prescriptions between 2016 and 2020 found that about 70% of antibiotics prescribed for adults were for 10 days or more.
So we're doubling down on duration errors.
Yes, we see opportunities to optimize both the agent selection and the treatment duration. Nearly one-third of encounters resulted in a guideline discordant agent, and about 75% of those with a guideline concordant agent had a longer than recommended duration.
Sore throat, or pharyngitis, is another massive contributor to this problem.
Huge. Modeling data suggests that sore throat accounts for approximately 5% of all antibiotic consumption worldwide, making it a critical focus area.
And based on 2020 population estimates, the estimated antibiotic consumption for sore throat in countries with observed rates was estimated to exceed 37 million courses annually.
37 million. And here's the crucial segmentation. Only about half of that consumption could be attributable to treatment for group A strep A, the actual bacterial cause that requires treatment.
To prevent rare complications, yeah.
Right. The other half, the remainder of those 37 million courses, is likely unnecessary prescribing for viral causes like the common cold or other viral pharyngitis, for which the drug is useless.
And then there's acute bronchitis, another illness that is overwhelmingly viral, but where overuse just persists stubbornly.
And a study looking specifically at acute bronchitis prescriptions highlighted individual provider habits as a truly significant driver.
What do you mean?
That study found extraordinary variability among providers treating acute bronchitis at a single health center.
So in the same clinic?
In the same clinic.
Oh.
We are talking about prescribing rates ranging dramatically from 0% to 80% for the exact same condition in the same patient population, sometimes even on the same day.
That's a huge disparity.
It is. It indicates that provider tendencies, clinical inertia, and diagnostic uncertainty rather than patient need are powerful drivers. Some doctors simply have a hair trigger for antibiotics, while others never touch them for this condition.
Finally, we should turn to a hotspot that is often overlooked in the medical and public health literature.
Dentistry.
Yes, dentistry. Stewardship tends to focus on medical doctors, but our sources show dentists wrote over 216 million antibiotic prescriptions between 2012 and 2019.
And the alarming trend here is that even while medical clinicians' prescribing rates decreased nationally during that same period, the overall dental antibiotic prescribing rate remains stubbornly steady.
And it was worse among specialists.
Exactly. The highest prescribing rates and increases over time were seen among dental specialists, specifically oral and maxillofacial surgeons, endodontists, and periodontists. The overuse isn't just in general dentistry.
This emphasizes the critical need for stewardship to extend across all healthcare disciplines, including surgical specialties in dentistry.
And our sources highlight an interesting insight into alternative treatments, particularly in dentistry shifting away from systemic antibiotics where possible.
You're talking about hydrogen peroxide.
Specifically, the use of low concentrations, like 1.7%, often delivered via customized prescription trays. It's a great example of looking beyond the traditional drug pipeline. Hydrogen peroxide is a broad-spectrum antimicrobial agent.
How does it work differently from a traditional antibiotic, which targets specific bacterial functions?
Well, peroxide works by physically disrupting the biofilm matrix that protects bacterial communities. When it's applied topically, it creates reactive oxygen species that physically destroy cell walls and the protective structure the bacteria build.
So it's a physical assault, not a chemical target.
Precisely. And the key advantage noted is that bacteria do not build resistance to peroxide through the classic resistance genes as they do to traditional antibiotics.
But they can adapt.
Right. The study notes that while classic resistance isn't an issue, bacteria are incredibly adaptable. They can and do develop a type of defense by increasing their production of specialized degradative enzymes.
So they're not evolving against the peroxide itself, but they're getting better at neutralizing it.
Getting better at neutralizing it before it can successfully break down the biofilm. It's a key distinction. It forces the bacteria into a different, less damaging form of adaptation for us. And for anaerobic organisms, bacteria that hate oxygen, the release of oxygen from the peroxide is simply lethal. It changes the microenvironment instantly.
Let's pivot now to how changes in healthcare delivery, particularly the accelerated adoption of telehealth, have created both new opportunities for data gathering and new challenges for antibiotic stewardship.
Telehealth, whether it's synchronous video or asynchronous store and forward care, it offers undeniable enhanced access, but often lacks the traditional in-person controls we've relied on for diagnostics.
So telehealth stewardship requires novel approaches because we lose that physical connection.
Absolutely. The CDC and other bodies suggest clear standards for telediagnosis, establishing precise guidance on when a virtual diagnosis is acceptable and when an in-person visit or a rapid lab test is absolutely necessary.
For example, for diagnosing strep A or acute otitis media, AOM, which require a physical visualization or a swab.
Exactly. And we can see the differences in behavior by directly comparing physical care versus digital care, using fascinating data that emerged from region Sörmland in Sweden. This contrast gives us deep insight into prescribing behaviors depending entirely on the setting.
And what did they find when they compared them?
They meticulously compared physical primary health care, or PHC, appointments to internet PHC appointments. For patients presenting with definite infection diagnoses, physical PHC appointments resulted in a shockingly high antibiotic prescription rate of 61.3% of the time.
61%. Okay, and what about the online visits?
The prescription rate for the exact same infection diagnoses during internet PHC appointments was dramatically lower, only 25.8%.
Less than half the rate.
Less than half the rate of their in-person counterparts. After adjusting for factors like patient age and gender, the odds of receiving an antibiotic prescription during an internet PHC appointment were significantly lower.
Which leads us to ask, why? Why did the digital model impose better constraints?
Well, our sources suggest it's because the internet PHC prescribers were found to follow regional recommendations more appropriately.
So the very nature of a digital consult changed the behavior.
It seems so. The inability to complete a full physical examination, you can't look in their ears or swab their throat via video, combined with the need to document the decision without that data, it forces the clinician to adhere more strictly to evidence-based criteria for systemic illness.
Criteria the patient often won't meet.
Right. So the digital environment, in a way, removes the ease of the unnecessary prescription.
Now let's look at the twist in the plot, courtesy of the COVID-19 pandemic. The emergence of the virus threw a massive wrench into this global system.
It really did. It disrupted years of established stewardship programs and significantly accelerated the overuse of antibiotics for viral respiratory infections across both inpatient and outpatient settings worldwide.
We saw an immediate panicked surge in inpatient prescribing at the pandemic's onset.
In March 2020, at the height of uncertainty, over 80% of patients hospitalized for COVID-19 received antibiotics.
80%.
And this high rate occurred despite continuous reporting that confirmed bacterial co-infection rates in COVID-19 patients were consistently low, hovering between 5 and 10%.
So this massive initial overuse was clearly driven by diagnostic uncertainty, the sheer severity of the disease, and a lack of established treatments.
Clinicians felt they had to throw everything at the patient to save them, including drugs that were proven ineffective against the virus itself.
And while those prescribing rates thankfully declined rapidly over the subsequent months,
They never returned to pre-pandemic baselines. They stabilized around 35% in 2022-2023. Critically, the misuse didn't disappear. It just became endemic to COVID care,
and the prescribing rates peaked again during major viral surges.
corresponding exactly to the Delta surge in mid-2021 and the Omicron surge in early 2022. It shows that even after the initial chaos, About 35% of COVID-19 patients without a diagnosed bacterial co-infection were still being prescribed antibiotics well into 2022 and 2023.
This is the definition of clinical inertia driven by fear.
It is. And the outpatient data mirrors this profound misuse. A study tracking trends found that the overall percentage of antibiotic prescriptions given for conditions where they are useless, the clearly inappropriate cases, rose from 25.5% to 27.1% during the 5-year study period ending in December 2021.
So the pandemic accelerated the growth of unnecessary prescriptions.
And the reason for the outpatient misuse was incredibly specific. Between March 2020 and December 2021, contact with and suspected exposure to COVID-19 was listed as one of the top 2 most common inappropriate reasons for receiving an antibiotic.
Incredible.
By the latter half of 2021, 15% of all inappropriately prescribed antibiotics were explicitly for a COVID-19 infection. The pandemic was not just a viral event, it was a major step backward for global antibiotic stewardship.
But if the systemic pressures of time, satisfaction, and fear drove this massive misuse, we have to ask who bore the brunt of this poor prescribing.
Let's examine this through the equity lens, because inappropriate prescribing is not distributed equally across communities or demographics.
So when reviewing the data on race and ethnicity, what did you find?
We find critical and complex nuances that defy simple explanation. In general, racial or ethnic minority groups were often less likely to receive antibiotics overall, less likely to be diagnosed with a condition warranting them, and less likely to receive broad-spectrum agents.
That seems counterintuitive to the general narrative of widespread overuse. Why the lower overall rates for minority groups?
Well, this points toward issues of access and diagnostic quality. Consider this example. Black children were found to be 30% less likely to be diagnosed with otitis media, an ear infection, and 25% less likely to receive an antibiotic for an acute respiratory tract infection.
Compared to other children seen by the exact same clinician.
Exactly. This may point toward unequal access to, or application of, diagnostics and treatment overall. They may be receiving less care, not necessarily better stewardship.
So lower prescribing isn't necessarily a win for stewardship. It may reflect structural issues where patients are underdiagnosed or undertreated for actual conditions.
Exactly. And the data gets even more complicated when we isolate only the unnecessary prescriptions.
What happens then?
Despite those lower overall prescribing rates for minority groups, studies show that when prescriptions were written, inappropriate prescribing was sometimes more common among Black patients.
What does that tell us about the quality of the clinical encounter?
It suggests a profound disparity in clinical decision-making. While white children may receive higher rates of broad-spectrum antibiotics, which is a common overuse indicator, Black patients may be receiving unnecessary antibiotics due to poorer diagnostic follow-through, less adherence to high-quality clinical evidence, or the clinician just having less time to dedicate to a thorough differential diagnosis.
So the problem isn't just quantity, it's the quality and necessity of the care provided.
It is.
Beyond race, let's look at geographic and socioeconomic factors, which show very clear patterns of risk that compound existing disparities.
There is a strong and persistent association between residents in the U.S. southern region and higher rates of antibiotic prescribing across various clinical settings.
And physicians in the South Atlantic region were significantly less likely to prescribe guideline concordant treatment than those in other regions.
Indicating a regional adherence issue, yes. And the issue of virality seems to compound this, perhaps due to limited access to comprehensive multi-specialty care.
Makes sense.
People living in rural areas were consistently more likely to receive both overall and inappropriate prescriptions than their urban counterparts. Compounding this, patients living in areas with greater social disadvantage.
Which is measured by a higher social vulnerability index, or SVI score.
Right. They were also more likely to receive unnecessary antibiotics.
For those unfamiliar, the SVI is a metric from the CDC that combines 15 socioeconomic and housing factors, like poverty, lack of vehicle access, and crowded housing.
And the connection between a high SVI score and inappropriate prescribing suggests that a lack of access to consistent, high-quality primary care and, crucially, proper diagnostic services may be the major factor.
So if a doctor can't easily order a rapid strep A test, or if the patient can't afford to come back for a follow-up,
the path of least resistance is often the unnecessary antibiotic. It's an unequal application of clinical inertia.
Finally, we have disparities related to age and sex that demonstrate who the system tends to overtreat.
The populations most susceptible to inappropriate prescribing are older adults, so those over 65, and younger children, typically under 10.
These two groups are specifically targeted as populations more likely to receive antibiotics for viral respiratory illnesses, perhaps due to a greater perceived risk of complications.
That seems to be the case. And regarding sex, female patients were generally more likely to receive antibiotics overall.
Is that due to conditions like UTIs or different prescribing habits?
It's likely a mix. However, one specific study in Tennessee provided a fascinating counterpoint. While women were prescribed more antibiotics in total, they had an 11% lower chance of receiving an inappropriate antibiotic compared to male patients.
So that's one of those crucial nuances that prevents us from making sweeping generalizations based solely on volume.
Exactly. It highlights the need to look at the clinical appropriateness of the prescription.
So, what does this all mean when we look toward the future? We've identified the core pressures on the doctor's desk time, money, patient satisfaction as the central behavioral drivers of the problem. How do we move past simple education, which clearly hasn't worked, and build tangible interventions that actually change behavior?
We start with the core architecture defined by the CDC: formal antimicrobial stewardship, or AMS, programs. These are necessary frameworks across all settings, hospitals, nursing homes, outpatient clinics, to monitor antibiotic use and intervene actively.
But the real measurable change comes from specific, targeted behavioral interventions that counteract those pressures we discussed earlier.
Exactly. And the intervention that seems to work best in the real world, because it leverages human social psychology, is peer comparison feedback.
Let's detail the findings from the randomized trial in Ontario, Canada, which targeted high-prescribing primary care physicians.
That trial focused on audit and feedback delivered through a single low-cost intervention: a mailed letter. The letter would clearly show the targeted physician how their prescribing rates compared to their local peers, specifically targeting the top 30% of prescribers.
And the results were clear and immediate.
This approach led to statistically significant reductions in both total prescriptions and prolonged durations.
Think about that. A simple low-cost letter, essentially, shaming doctors by showing them their rank, had a bigger impact than years of generic education.
It leveraged social comparison, the fear of being an outlier, to drive behavior change. And the specific results were robust. The intervention-limiting antibiotic duration, the so-called duration letter, was found to be highly effective.
How effective?
It resulted in an average of 42 fewer antibiotic prescriptions and generated $771 in drug cost savings per PCP over a 12-month period.
That is a massive return on investment for an inexpensive letter.
It is, and there was a specific demographic that responded particularly well to this type of intervention:
Who was that?
late career PCPs, those 25 or more years post-graduation. This suggests that simply providing an objective external measurement and showing physicians where they stand relative to their colleagues can successfully disrupt decades of entrenched traditional practice habits.
And furthermore, we have evidence that combining several of these low-cost strategies creates sustained success, which is the key to winning this long war.
Right. A study in a VA system implemented a multifaceted stewardship intervention combining clinician education, peer comparison, and crucially, computer decision support tools. They achieved a remarkable 35.6% reduction in overall prescribing during the intervention period.
And the key finding here is durability.
Exactly. The effects were largely sustained, holding at a 26.8% reduction, even after the active peer comparison component was stopped. This demonstrates the power of embedding the change into the system itself, rather than relying solely on external pressure or individual motivation.
This brings us directly to systemic and technological nudges, particularly within the electronic health record, or EHR, and virtual telehealth platforms.
If we can't change the doctor's mind every time, we must change the default option.
And these clinical decision support tools are absolutely essential for that.
They act as automated nudges by manipulating the choices presented. They guide prescribers toward recommended therapies by presenting guideline-concordant treatments in preferential order, making them easier to select.
Or they use what's known as hard stops, requiring a written justification for ordering non-recommended broad-spectrum antibiotics.
These tools counteract that critical 1-minute time constraint we talked about earlier. If it takes longer to write the wrong prescription than the right one, the clinician defaults to the evidence-based choice.
And for telehealth environments where physical posters or reminders are irrelevant,
The commitment to stewardship must be displayed visually right within the virtual visit platform. It's a virtual nudge that replaces the physical context.
And these technological nudges are profoundly powerful for solving the duration problem, especially in high-volume pediatric care.
Yes, Take acute otitis media, AOM, in children. It's a common bacterial infection, but over 90% of children were historically receiving unnecessarily long durations of therapy, often 10 days or more.
And these interventions have been shown to be highly effective.
Yes, a more intense intervention combining education, peer comparison, and EHR modification achieved up to a 76% absolute increase in prescribing guideline-concordant short durations, specifically 5-day courses.
This shows that when you successfully change the platform, you successfully change the default behavior for the better.
Without doubt.
Finally, we must consider prevention as the ultimate act of stewardship. If we remove the disease, we remove the need to prescribe.
And we should highlight the transformative potential of a vaccine against Group A strep, which is the bacterial cause of some sore throats.
What could that do?
Modeling suggests that a strep A vaccine, by reducing the rate of infection in children, could reduce antibiotic prescribing for sore throat by a massive range, from 32% to 87%, depending on the vaccine's efficacy.
That is enormous potential reduction in unnecessary drug exposure.
It is. However, the source material emphasizes a fascinating finding beyond just the science of the vaccine.
Which is?
The finding is this: reducing precautionary prescribing, that is, actively changing doctor behavior, in combination with vaccine efficacy, is projected to have as much, if not more, importance than the vaccine efficacy alone.
So we have to address the clinician's hand and the systemic inertia, not just the pathogen itself, to realize the full public health benefit of any future vaccine.
That's the key takeaway.
This has been a dense but essential journey through the sources, tracing the crisis from the laboratory to the doctor's desk. We started with Alexander Fleming's incredible foresight and have charted the path to a modern, multi-billion-dollar crisis driven by the most mundane of human behaviors.
Trying to save a single minute or seeking to avoid a negative patient review.
And we've seen that the war against antimicrobial resistance is fundamentally a dual struggle. It is fought in the lab, where new drugs are desperately needed, but primarily
in the consulting room, where the fear of liability and the quest for 5-star ratings often override evidence-based medicine and public health responsibility.
the dilemma of the single unnecessary prescription is what we call a low-impact ethical decision that, when aggregated 47 million times a year, creates a massive public health crisis.
And the best course of action consistently seems to lie not in trying to ethically rewire every individual doctor, but in promoting consistency in practice and optimizing the communication between clinicians and patient through powerful systems.
Which raises an important question for you, the learner, to explore further. We've seen compelling, quantifiable data showing that behavioral and technological nudges like peer comparison letters or forcing written justification for non-recommended prescribing through the EHR may ultimately be more reliable drivers of change than relying on a clinician's already overwhelmed capacity for ethical deliberation and complex evidence recall.
So when you look at the scale and complexity of this issue, which mechanism of change policy and regulation, technology and defaults, or ethics and personal responsibility will ultimately prove to be the most successful and sustainable weapon in the war against the superbugs?